Good afternoon. It's a pleasure to be back at PedirhythmX and also to visit Boston for the first time in several years. Today I'll be speaking on the subcutaneous ICD and its role in congenital heart disease, as well as primary prevention indications in Eisenmenger and other conditions. The entirely self-contained subcutaneous ICD sits at the side of the chest with a subcutaneous coil. There are no intracardiac or epicardial leads. The advantages are obvious. Without an intracardiac or indeed epicardial lead, the risk of lead displacement, extraction, infection, pneumothoraces disappear. And for epicardial systems, effusions, patch coil and pace sense failure are no longer present. It is ideal in congenital heart disease with no venous access, Fontans, Glens, previously occluded veins, and in the setting of right to left shunts where there's a risk of thromboembolism, single ventricles, unrepaired, and Eisenmenger. There are some disadvantages. The sensing vector is unsuitable in some. The device is bulky with pocket discomfort in those with a low body mass. There's no pacing, either backup or anti-tachycardia pacing, and there can be interference with existing pacemakers. Here you see a subcutaneous device alongside a standard transvenous device, and in this low body mass individual, it is protuberant and looks uncomfortable. How does it compare to the transvenous ICD? These 4 studies are all meta-analyses of, again, non-congenital comparative studies. Here 5, 13, 26, and 5 studies looking at the differences between the two systems. In virtually all the studies, lead issues are predominantly via the transvenous route. Pocket problems and infections are slightly increased in the subcutaneous ICD, although in some studies there does not seem to be a difference, and in one, transvenous pockets were more of a problem. Shocks, inappropriate shocks, there does not seem to be a difference. And overall, 3 of these meta-analyses confirmed that there was no significant difference between the two systems, and 1, in fact, thought there were increased problems with transvenous systems. It is important when implanting one of these devices to confirm eligibility. You need to make sure you have a good sensing vector. Here you have a QRS complex where the T wave is so big it falls outside the zone and therefore would lead to double counting and inappropriate shock. This signal shows a T wave of good amplitude and a QRS complex so that there would not be any double counting. It's important to check on both sides of the sternum, as the sensing vector may be better on one or other side. It is also important to screen during exercise. Here you see a patient with a minimally prolonged QRS complex, but during exercise there's much more bundle branch broadening, and you'll notice the increased QRS, but also with a very deep T wave, and this may lead to inappropriate shocks. The other cause for inappropriate shocks can be pacing itself. Here, this patient with a failed epicardial ICD has a subcutaneous ICD placed, has had 2 inappropriate shocks. The one is for supraventricular tachycardia, which is difficult to program against other than on rate criteria. But here, this inappropriate shock is due to T wave double counting and may be related to pacing in this patient. How eligible are patients with adult congenital heart disease? In 100 patients tested, only 60 patients passed screening, and females were better than males. Vectors were suitable in both left and right sternal positions in 55%, on the left in only 20%, and in the right on 26%. Patients with tetralogy failed in 50% of cases, and with the Fontan failed in 70% of cases in the study. This study shows very different results. In 100 patients, 20% with tetralogy and pulmonary vascular disease in 11%, 83% of patients passed. Again, they noticed that the majority had good sensing vectors in both the left and right parasternal position, but some patients only the left or the right parasternal position would work. Looking at studies at how eligible patients are, these 4 studies, the mean of 300 patients gives 77% eligibility. The 2 more recent studies that I've just shown, one showing 83% and one showing 60%, are probably just averages around this mean, and probably 70% plus patients with congenital heart disease are suitable for a subcutaneous ICD. Interestingly, this study, with only 30% of Fontans being eligible, in this study, 90% of Fontans were eligible. Again, if you're going to implant a pacemaker at the same time as an ICD, this patient needed atrial pacing to allow him to tolerate beta blockers after a cardiac arrest. And using a bipolar pacemaker, there's far less interference with the subcutaneous ICD. And it's important to test pacing that it does not interfere. What studies have been performed? There are a number of case reports in the literature and a few small series. Here are 20 patients at a single center, 8 of them with unrepaired or palliated univentricular hearts, primary prevention ICDs in third, inappropriate shocks in 10% and appropriate shocks in 15%. 1 patient had an infection and the device was removed, and 3 died from non-arrhythmic causes. A second series, 14 patients, univentricular, tetralogies, mustard patients, primary prevention in a higher proportion, 57%, a similar number of shocks, both appropriate and inappropriate, and again, as in the previous study, high-risk population with 4 requiring transplantation. Here you can see subcutaneous ICD in a patient with dextrocardia, and as long as the vectors are appropriate, it is suitable. It is also possible to combine the subcutaneous ICD with leadless pacemakers, and this may be something used more frequently going forward. So clearly, the subcutaneous ICD has a good role in adult congenital heart disease. What about primary prevention? We are hopefully no longer relying on anecdotal implants where evidence from one case is used in other patients, but equally the guidelines are starting to become overpowering with increasing numbers of guidelines. In this field, the 2014 is a PACES HRS consensus statement, in 2015 ESC guidelines for patients with ventricular arrhythmias, in 2017 AHA HRS guidelines, in 2018 the congenital heart disease from European Heart Rhythm Association, in 2018 AHA guidelines in adults with congenital heart disease, in 2020 ESC guidelines for adult congenital heart disease, and in 2021 the PACES group for pediatric patients also commented on adults with congenital heart disease. All these guidelines come out with indications. They class them type 1, 2A, 2B, and class 3 I've left off here, and then come up with evidence levels A, B, C, D. At this point, you'll notice a lot of Bs and 3 primary or 3 class 1 indications. As we move through the years, these change slightly here, and 2 class 1 indications, and the levels of evidence have now become C for these same conditions. The congenital group in the ESC use traffic light system with green, yellow, and red. I've left those off the screen. And the pediatric group commented on patients between 18 and 21. Age 18 and above is adult congenital in the rest of the world, but in the US, this pediatrics covers up to 21. Looking at some of the indications in more details and just taking the European guidelines in 2015, I think everybody agrees with class 1 indications of survivors of an aborted cardiac arrest or symptomatic sustained VT. Slightly more contentious is those patients with a systemic left ventricular ejection fraction of less than 35%. You notice the evidence levels change over the years, and this particular one has been a class 1, it's become a class 2B, then a class 1, back to a 2A. Class 2A indications, most people agree on those for tetralogy of Fallot with multiple risk factors, patients with syncope of unknown origin and ventricular dysfunction or VT are class 2A, and then patients with a systemic right ventricular dysfunction are usually a class 2B. Again, the indications, levels of evidence have changed to a C in most cases. And here again, for syncope, notice it's a 2A, becomes a 2B, back to a 2A. You might look at a cynical view of guideline development. They, US, Europeans, adults, ACHD, EP, etc., publish a guideline. We, whichever group we belong to, respond. We choose our old guideline members and a few new. We rehash, build on the evidence from previous guidelines. We find new insights, adjust something, evidence levels, definitions. New consensus is based on previous committee experts, opinion from larger centers, persuasive arguments, fashionable opinion, recent studies. There's then usually agreement from external society nominees from some of the other groups, and then this gets published. And then one starts preparation for the next version. And then while preparing this talk just 3 weeks ago, the 8th guideline in 8 years on the primary prevention ICDs in adults with congenital heart disease came out. And you'll notice here that the ejection fraction of less than 35% in congenital heart disease is back up to a class 1, although evidence level remains C. How do these guidelines perform? They have been tested infrequently. This is a single center study of 131 patients with an ICD, 69 for primary prevention, 55 had CRTD, and in 23 there was an appropriate shock. And they looked at the rate of shocks depending on the class, and they found that in class 1 there was about 7.6% per year, and in class 2B only 2% per year shock. It's important to remember that class 1 includes those with secondary prevention rather than purely primary prevention. But they concluded that there was a reasonable need for shocks over time and that the guidelines were effective. Looking at it the other way, this is a study looking at 25,000 adult congenital patients at 3 centers followed for over 20 years. There were 157 sudden cardiac deaths with 292 matched controls. 33 Eisenmengers were excluded from the HRS guidelines where they are class 3, but included in the ESC guidelines. But looking at it, the sensitivity for an appropriate shock and treatment of prevention of sudden death was pretty low. For the Heart Rhythm Society guidelines, 41% of sudden cardiac death patients had an indication, meaning 60% of patients would not have received an ICD. And equally in the group of controls who did not need a shock, 17% of controls had an ICD indication. The same group then tried to devise a scoring system to see if they could better the guidelines. They grouped patients from more severe Eisenmenger to Epstein's, Fontan, down to tetralogy and closed ASDs. And they looked at the number of risk factors to see what the annual risk of sudden cardiac death was. So for instance, an ASD with 1 risk factor has less than 1%, whereas an Eisenmenger patient with 1 risk factor has a 4% annual risk of sudden death. The risk factors were coronary heart disease, heart failure, SVT, systemic or pulmonary ventricular ejection fractions less than 40%, slightly more liberal than the conventional guidelines of 35%, a QRS duration greater than 140 milliseconds, and QT dispersion of 70 milliseconds. And they said that if the risk was above 3%, they considered these patients to be high risk. They then went on to validate this in a prospective study of 783 patients followed over 2 years. Of these, they thought 58 were at high risk, 2 had sudden cardiac death, and 2 had VT or VF. However, of the 725 who were low risk, 2 also had sudden cardiac death, and 2 had VT-VF. If we look at these self-same patients and look at the ICD indications according to the HRS ESC guidelines, 19 of these patients had an ICD indication, but there were no sudden cardiac deaths and 2 VT or VF. Of the 764 who had no indications according to the ESC guidelines, 4 had sudden cardiac death and 2 had VT or VF. And they concluded that the sensitivity was far better using their scoring system than the guidelines. A different predictive model was developed by the Spanish ACHD group. They looked at a single center cohort of over 3,000 patients over 25 years. They also looked at a multi-center study, 20 centers, 207 sudden cardiac deaths, and 2,000 controls. The sudden cardiac death and cardiac arrest incidence at 5, 10, and 20 years was 0.7, 1.8, and 3.1%, so relatively low. They then grouped these patients into lesions similar to the previous scoring system, then looked at clinical variables, univariate, multivariate, probabilities, linearity. They calibrated their model and validated it using receiver operator characteristics, etc. And then validated it in 2 centers using 63 sudden cardiac death patients with 786 controls. And they concluded that their scoring system was better than HRS or ESC guidelines. Just to show their groupings, they only had 4 groups as opposed to the previous system with more. Left to right shunts, right ventricular outflow tract lesions scored 0, left heart lesions and arterial switch scored a 1. Tetralogy, Epstein's, mustard, and Fontans scored 2, and it was complex tetralogy, Rastelli, pulmonary vascular disease, and unrepaired conditions that scored a 3. They then drew up an online calculator where you could input the data, inputting the lesion-specific data, the age in years, sex, 1 or 0, unexplained syncope, ischemic heart disease, sustained VT, QRS duration in numbers. And then they concentrated on moderate to severe systemic and pulmonary ventricular hypertrophy, as well as subpulmonary dysfunction. They came up with a 5-year sudden cardiac death predictor. And when this prediction was more than 5%, they felt that the true positive rate was 54% with a specificity of 95%. They were confident these patients should have an ICD. Less than 0.1%, they felt follow-up was required, but for those in-between risks, they thought that further testing with cardiopulmonary exercise, MRI, and EPS were required. So how does these calculators perform? Well, this is a patient of mine with tetralogy repair, restrictive VSD, mild pulmonary stenosis, right bundle branch block, and a QRS of 180. So on the system, he gets a 2 for his tetralogy, age 42, 1 for male, 180 milliseconds QRS, and 1 for right ventricular hypertrophy. He comes up with a score of 3.42, which does not merit an ICD in their system. 5 years later, He's had a flutter ablation. He had VF due to catheter movement, but no VT stim performed. And again, because of his age, the risk has actually gone down. It's 3.08. And 10 years later, his risk has gone down further, again, because of the age factor. Interestingly, if he were to develop left ventricular hypertrophy from hypertension, for example, and this is hypothetical, he remains well, his risk would suddenly shoot up to 8% and he would require an ICD. Looking at the self-patient using the prevention ACHD score, he has tetralogy of Fallot. He had risk factors, he's had an SVT and his QRS is above 140, gives him 2 risk factors, and he has low risk and does not merit an ICD. I'm not sure what would happen now that his SVT has been ablated, whether this means he only has 1 risk factor. Moving on to Eisenmenger's in the scoring system. Here's an example from the literature of a patient with a subcutaneous ICD in Eisenmenger's. My patient is 30 years old, ventricular septal defect, saturations of 88%, right ventricular hypertrophy, and a QRS of 150 milliseconds. Patient has mild exercise limitation, but not able to partake in sport. For the Heart Rhythm Society 214 guidelines, this is a class 3, Eisenmengers are contraindicated. For the ESC in 2015 and subsequently, Eisenmenger's is not a contraindication, but there is no indication in the absence of severe ventricular dysfunction, syncope, or arrhythmias. The prevention ACHD scoring gives him 1 risk factor with a QRS of 150 milliseconds, and with an Eisenmenger has a 4% risk and should get an ICD. The Spanish predictive model, if this patient was a male, gives a risk of 5.75% and should have an ICD. But if this patient was a female, then it would only be 3% and no ICD would be merited. And this scoring system is the first one that stratifies based on sex. So what do we do now in 2022? Is it no to guidelines and yes to lesion-based scoring? Well, both scoring systems claim better predictions than the guidelines, but neither is perfect. A mix of categorical and continuous variables that are different to each other. The validation is only in very small cohorts and over very short periods. What really is needed is to test the guidelines and both scoring systems against each other, and perhaps more importantly, to test the scoring systems against the prospective patients that they use to validate their systems. But in addition, these need to be tested against large retrospective cohorts and prospectively. And perhaps these will allow refinement to get better scoring system. It may be, however, that MRI input will be even more predictive than any of these. So when it comes to our patient, we use the guidelines that are based on evidence. There's usually a consensus, and anecdote has been relegated. At the same time, we need to balance this with individual assessment, risk-benefit analysis, patient counseling, and patient autonomy to come to an informed shared decision. The 2 scoring system may feed into this, but currently there's not enough evidence for these to outweigh what we currently have. Hopefully in the future, these will lead to that. So in conclusion, the subcutaneous ICD is ideal for complex adult congenital heart disease patients with no need for pacing. Screening is essential to avoid failed and inappropriate shocks. The guidelines for primary prevention ICD implantation are imperfect and have changed little over the past 8 years, but are currently the best we have. Scoring systems for primary prevention ICD show promise, but need additional validation and refinement. Guidelines and scoring do not replace clinical judgment, and patients must continue to be involved in decision-making. Thank you, and I'd like to thank the organizers once again for this excellent meeting.